I want to welcome you to this second part of the webinar, a follow-up, if you will, to the first panel webinar that we had on computerized physician order entry. My name is Paul Moore. I'm the Senior Health Policy Advisor with the Office of Rural Health Policy and a pharmacist by education. What we hope to accomplish during this session today is to remind ourselves why it is so important to take action to improve medication management and patient safety, to become familiar with some ways to increase pharmacist engagement in the process, and to recognize some of the policy and regulatory issues around remote pharmacist services. Also hope to review some guidelines for implementation of remote pharmacist services and to become aware of programs and initiatives supporting this call to action. As a way of review, the first webinar was more of an overview of the subject. And it was to help us recognize the challenge for all hospitals in the area of medication management and patient safety, but especially the challenges for small rural hospitals in implementing CPOE and in accessing pharmacist resources. Now, we took a fair look, pointing out the advantages and the limitations of CPOE as a tool for improving medication management and reduction of medication errors. But the good news that we ended on is we discovered there are proven strategies that work to improve medication management and patient safety in small rural hospitals. One such strategy that we discussed is actually a matter of leveraging the very technology itself to access the remotely located pharmacist in order to provide enhanced medication management and patient safety for the patients of low-volume rural hospitals in a way that makes sense, clinically, financially, and demographically. A conduit, if you will, moving the resource to the need, providing better care and better outcomes, and at less cost. But as we pointed out in the first webinar, there are other factors beyond the technology and what it can do which come into play. Factors such as the increasing rate of introduction of so many new pharmaceutical products. You know, just this one thing has increased the difficulty of pharmaceutical management of patients, and it has amplified the importance of expert pharmaceutical consultations with a resulting increased reliance upon the pharmacist. In the first webinar, we also noted that most electronic systems are not yet sophisticated enough to identify situations when doses of medications should be adjusted. Adjustments made based upon the patient's renal or hepatic function or fluid status or any other number of things. For these reasons, pharmacist review of orders will continue to serve an important role in ensuring optimal therapeutic outcomes and patient safety. That's because even with the advances such as CPOE, medication order review by a pharmacist remains the standard of care. And you know, our patients don't want different standards based on the size of the hospital. So how do we maintain that standard, especially in small rural hospitals? The solution we discussed is to find a way to engage the medication experts, the pharmacist, engage them in this process in a way that makes sense, in spite of the challenges. One solution: remote pharmacist review of medication orders. So, during this webinar, we will explore different models of remote pharmacist services. We'll discuss policy and regulatory issues, examine existing guidelines for implementing the service, and we will point to programs and initiatives that are moving us toward enhanced medication management, moving us toward a reduction of adverse drug events, and better care, better health, and less cost to our healthcare system. You know, the technologies used in remote medication order processing are no longer all that new. They've been around for a while. But along the way, different methods for accessing pharmacists remotely have evolved. And the key in whatever method is to find the method or model that most closely fits your facility's need and resources. So we will examine the most common methods, that being, first of all, network agreements and contracted services. And then we'll explore a twist, if you will, on a method used by larger hospitals and health systems that could have some positive potential for smaller hospitals. So let's start by looking at network agreements. You know, the scope of critical access hospital networks range from maybe a large health system ownership of multiple CAHs in conjunction with ownership of larger hospitals to maybe what you would call a health system management of the critical access hospital, even down to what you would call non-owned or managed, but still highly organized formal co-ops of critical access hospitals. Situations where the CAH has buy-in and direction of the network, usually with the robust co-op resources and also some negotiating leverage that goes with that. And these type of networks or co-ops usually offer a wide menu of services. And those are different levels of it, but it even goes down further than that to what I would call a more loosely affiliated network formed by a few hospitals for only one or two specific purposes. And one other point you're probably aware of, CAH networks come in all sizes, from including almost every critical access hospital in the state to perhaps only a handful who are collaborating for a specific purpose. But in each case, the idea is to reach an economies of scale that is unavailable to the individual hospital. And any of these network structures could be used to leverage pharmacist resources in a cost-effective way. The second common method is contracting for services. And as you talk about this could range from contracting with huge healthcare companies to maybe regional providers to even small companies who perhaps are only focusing on critical access hospitals. And another method or twist of this contracted services is a sort of a hybrid of the previous health system models we mentioned, where there is no ownership or management relationship of a larger hospital with the critical access hospital. But what there is 24/7 pharmacist resources available. So the critical access hospital contracts with the larger hospital to access those resources, most likely on a limited basis. It's an example, if you will, of the haves simply helping the have-nots, and the have-nots, the critical access hospitals, helping to pay for those resources. Now, I'll be honest with you. In reality, this model does require a good relationship and a willingness of the frontline staff at both facilities to appreciate different perspectives. More than once, I've seen pharmacists at a large facility that are so used to owning the entire medication management process that when they first come across a critical access hospital where the process in reality is owned by nursing staff, that they just can't believe what has been asked and put upon nursing to do. But once the connection is made and once that they see from each other's perspective that they're really on the same team, then you see things start clicking and things start working. And so it does provide an opportunity. Once they appreciate the different perspectives, it can and does work in some situations. Now, another hybrid approach to this one that we've talked about could be a homegrown model. An example of this would be where a critical access hospital either has or desires to have their own in-house pharmacist. But honestly, they really have trouble justifying the cost of full-time pharmacist services based on their patient load. And so what they do is they find a way in which they could then share that resource with other critical access hospitals, perhaps on a contractual basis, and use that revenue to help pay for the pharmacist. This model can be a win-win for all, and you're working off the same perspective because you're both critical access hospitals. But with any of these contracted models, There can be a menu of services provided along with the remote pharmacist services. Services such as formulary evaluation, developing drug administration protocols, developing policies and procedures, perhaps ensuring compliance with regulations and accreditation bodies, even to working on the pharmacy budget, quality control, participating in hospital committees and teams. It could be a menu of a la carte services that are available, perhaps at additional cost or fees, but in any case, still an economies of scale that is less expensive than trying to go it alone. Now, I mentioned a twist. So similar to the models already described is a situation in which a health system with a number of hospitals relies on the ones that have 24-hour pharmacy departments, or maybe they rely on a contracted service to provide remote medication order processing for hospitals whose pharmacies have closed. Maybe they close early in the evening, or that maybe during the day they experience unanticipated peaks in order processing workload. Now, I'll admit, this is typically the domain of the larger, fully integrated hospitals. Critical access hospitals don't usually experience huge, unanticipated peaks in order processing workloads during the day. But even in the case of critical access hospitals or a network of CAHs, this concept could still provide benefits such as access to specialized expertise and on-call flexibility and economy of scale. And the potential twist of this concept that I want to put out is just this. What if, again, the critical access hospital desires to have in-house pharmacist capacity but has difficulty justifying based on census or workload? Why couldn't that hospital provide the staffing flexibility that other hospitals need and thereby help pay for their pharmacist at the same time? And I'm not just talking other critical access hospitals. If the resource is there, you could even help staff during unanticipated peaks at a larger hospital. It's just a matter of leveraging the resource you have in the most cost-effective way and also helping find ways to pay for it. Standard technology makes all this possible. My point is we need to think beyond our current situation to meet our current needs. Now, in considering the implementation of remote pharmacist services, there are some regulatory considerations, and as you might guess, they vary. State regulation of remote medication order processing varies considerably from state to state. The critical access hospital and the remote pharmacist provider should both together jointly analyze their own state's regulations governing pharmacy practice at both the hospital and wherever the remote pharmacist is located. They need to determine and meet the applicable requirements. And I'll go one step further. They need to look back and analyze it from time to time, and it should be reviewed on a periodic basis because sometimes regulations change. So to ensure a regulatory compliance, at a minimum, there are some things that should be verified and approved by the hospital and the remote provider before implementing remote medication order processing. Things such as the remote provider's approval to operate by the hospital state board of pharmacy. In some states, this is more restrictive than in other states. In some states, there are different mechanisms set up, like maybe the state board of pharmacy licenses the remote provider. Maybe they require licensure of the pharmacist involved. Different things are involved. One thing that almost always will be requested will be the policy and procedure manual for the remote medication order processing operation for the remote pharmacist. I know they will also require copies of all licensure required by the states in which the hospital and the remote pharmacist are located. Many states require each remote pharmacist to be licensed in that state of the hospital for which the pharmacist performs the services. Some states just require that the remote medication order processing entity and the pharmacist in charge of that remote medication order processing company be licensed in the state. Other considerations would be if the hospital itself has credentialing requirements or any special competency requirements. Some hospitals credential their pharmacists as members of their ancillary medical staff. So these are the questions you need to ask, and these are the things that you need to take care of up front. Now, I'm going to go over some practice guidelines with you as an overview, but I just want to tell you this. You don't need to try to write every bit of this down or to capture it while you're watching this webinar. There will be a link at the end of the presentation where you can access these in detail. But as an overview, the purpose of practice guidelines is to describe the policies and procedures that must be in place to safely employ remote medication order processing. So, your hospital's policies and procedures regarding remote medication order processing should reflect what you're doing and what you've added to the way you do things. And they should address quality assurance and safety. They should address accessing information and policies and procedures of your facility. They should address training and orientation, both of your staff at the hospital, but also of the remote pharmacist staff. They need to address technical specifications, confidentiality, privacy and security, and then also, and so very important, communication. And I would even go a step further, problem resolution, because problems will pop up. And because of the differences in practice settings and remote medication order processing models, certain aspects of these guidelines may not be applicable to all settings. But you need to look at them, and you need to take which ones do apply to your setting and make sure that you have those in place. You will also note in the context of our leveraging technology to access pharmacist services that we spoke about in the first webinar, that these guidelines address remote order verification only when medication order fulfillment occurs through an automated medication storage and distribution device. Now, that's just a long name for what you know as some proprietary names like Pyxis, Omnicell, those type of things. The medication distribution cabinet itself that nursing goes to retrieve the medications from. Now, in addition, these guidelines don't attempt to address other aspects of remotely delivered pharmacist care that can be accomplished and that are really a good way to use the resources of having access to remote pharmacists to accomplish. Things such as a post-discharge medication reconciliation. These guidelines just address in-house remote medication order processing. So let's look at them. The first one on the list was quality assurance and safety. Medication management and safety in the remote pharmacist environment requires special efforts in the coordination of quality assurance, performance improvement, and patient safety practices between the hospital and the remote pharmacist. Differences in local practice and organizational culture combined with the ever-present human factor issue, these differences have the potential to magnify the risk of errors. I like to say it this way. You're moving someone's cheese and you're disrupting. It's like stepping into their kitchen almost and cooking. You know, things are going to be out of place, and so it takes a lot of communication and a lot of working together. And you will run into things that, you know, when I talk about culture, it's, well, we've always done it this way. Understand that, but then also understand that there may be better ways to do things. So, quality, safety, and risk management strategies should be jointly examined and agreed upon as much as you can ahead of time, and should address the procedures and communication pathways that are unique to the system that you are building into a system of remotely monitoring and reviewing medications and ordering systems. These include such things as the review of the patient's profile, and you're probably aware of this, but just to tell you what that would involve would be like the patient's history, their diagnosis, if they have any allergies, if they have duplication of therapy. Maybe they've been on a medication at home. When they come into the hospital, there's another medication added that would duplicate the therapy they're already on. Potential drug interactions between medications that they take. You need to be able to have access to their lab values and things like their height and weight and age and gender. All these things are part of the patient's profile. Then there's also the matter of the workflow steps and handoffs that have to be involved in medication ordering and review and verification. These are critical workflow steps that need to be understood. Also a process for reporting and tracking medication errors and pharmacist interventions. For assessing the patient's response to a drug therapy and achieving desired therapeutic outcomes. There also needs to be a process for communication among prescriber, pharmacist, and nurse. This cannot be overemphasized, this ability to rapidly and effectively communicate back and forth between all the caregivers. And I would say, finally, the ability to monitor and improve the performance of the remote pharmacist team. You see, as we talk about quality assurance and safety, we usually think of where the patients are and think of the quality assurance and the safety things placed at the hospital. But there's also an opportunity here to monitor the performance of the remote pharmacist. And so you need to look at that as you're discussing this ahead of time. You know, how will you know the level of service that you're getting from the remote pharmacist, and how will you be monitoring and documenting that? Moving on to the information that we've talked about, you know, there's a need for drug information resources in the practice of pharmacy. They also need to be available, and you should at a very minimum meet the State Board of Pharmacy requirements for both the hospital and the remote pharmacist service. And in those states that license both, there will be a very clearly defined, in the regulation, a clearly defined description of what the library needs to be. Now, these can include they should include current editions, but they can also include hard copies or electronic access to these drug information references. The remote pharmacist must also have access, in addition to those resources, access to internal clinical information such as lab values and other information, patient information that we mentioned a while ago. They need access to the hospital's formulary. They need to know, I mean, they're not there in the house. They need to know what is available, what that hospital has set in as formulary. And this needs to include such things as automatic substitution lists, automatic stop orders, maybe standard medication administration times. If there are any prescriber-specific standing orders or drug protocols, any information like that, it is so important that the pharmacist, the remote pharmacist, who, by the way, is joining your hospital team, needs to have access to that. And very, very important, the hospital's pharmacy and nursing policies and procedures. Once again, I mentioned the remote pharmacist is joining your team, and as such, they need to understand what policies and procedures your hospital operates under, because their policies and procedures will be incorporated into those, and wherever there's something that needs to be tweaked, they need to be a part of it. They also need to understand and have access to the nursing policies and procedures, because they will be working very closely with the nursing staff, and they need to know that there may even need to be some changes to the nursing policy and procedure when you adopt remote pharmacist services. The main concept here is to remember we're all on the same team, and the remote pharmacist is actually joining your hospital's clinical care team, medication management, and patient safety team. So that's obviously going to involve some training and orientation. Training and orientation are critical for the remote pharmacist to accurately document and transcribe the appropriate information to maintain an accurate and up-to-date patient profile in your hospital's order entry system. Now, the requirements for training and orientation will include such things as each remote pharmacist accessing the pharmacy order entry system being trained and tested for competency prior to the use of the system and then again periodically thereafter. It's so important. These remote pharmacists need to understand how to navigate within any number of systems, because as they work for different hospitals, they will come across different systems. The key for your relationship with them is that you are confident they know their way around your system and are competent in the use of it. And then as system upgrades happen or significant changes to your computer software, the hospital should communicate to the remote pharmacist the need for follow-up training, and that training should be documented. When significant changes are made to the hospital's clinical policies or procedures, these usually are generated by your medical staff. And so whenever that happens, the hospital should communicate to the remote pharmacist the need for follow-up training. And then once again, it's the hospital and the pharmacist's responsibility to make sure that any of this training and any of these competencies are documented. Now, regarding technical specifications, I mean, it sort of goes without saying, but we'll say it anyway. The biggest thing you've got to work with here is the remote pharmacist must have the ability to access the hospital's order entry network. And I'll say that again because you don't want to take it for granted. It's a big thing. Full access to the hospital's pharmacy order entry network. And this also includes other ways of accessing the hospital, including telephone, scan, or fax access to the clinical staff. The remote pharmacist must also, to whatever extent possible, have redundant systems in place to ensure that the remote medication order processing that's going on, that it's available. In other words, backup plans, a computer network or internet connectivity, other information systems to use to facilitate the service they are providing. The remote site must also have the ability to operate remotely the client's order transmittal system. It needs to be as if they were right there in your facility, standing in front of your system themselves. So there must be also archival capacity for all the patient orders and any pharmacist interventions that are generated. One reason is that most state boards require that records be kept. And if there's remote pharmacy order entry or remote pharmacist services being utilized, there's usually a requirement that any orders that they've reviewed and any interventions that they have made be documented and retained for a period of time. So there needs to be capability to archive those. And last, but definitely not least, the systems used by the remote pharmacist to view the patient orders and other medical information must comply with the technical standards set by HIPAA. And they must ensure technical and physical safeguarding of protected patient health care information, which brings us to this next topic, and that's confidentiality and privacy. In order to ensure the confidentiality, privacy, and security of patient health care information, there are some important issues to address up front. For example, remote pharmacists must agree to adhere to the hospital's confidentiality policy. The remote pharmacist service, if it is a business entity, must also have a signed business associate agreement with the hospital. The hospital must provide individual pharmacist-specific access to the client's hospital computer system, and this cannot be the same for all of the pharmacists that may work for the remote order processing entity. There has to be individual pharmacist-specific access. This is the individual IDs and the individual passwords. There must be a clearly defined archival system which ensures privacy and also meets the regulatory requirements for retention of documentation. And there should be a periodic review and documentation of compliance on all of these issues. Now, if there's one thing I've mentioned time and again, and I told you I couldn't mention it too much, it is communication and problem resolution. To ensure the safety of the remote service, the hospital and the remote pharmacist must establish consistent, effective communication channels. There must be communication among prescriber, pharmacist, and nursing staff because it's critical to assessing the patient's response to the drug therapy and achieving desired therapeutic outcomes. The remote pharmacist must have the ability to immediately contact the prescriber or nursing staff to discuss any concerns identified during review of the patient's information. The remote pharmacist must provide nursing a 24-hour telephone number to contact them and encourage the nurses to communicate with the remote pharmacist. That you see, you might say, wait a minute, if the shift is only 6 or 8 hours long for the remote pharmacist, shouldn't that be the only time? No, any time during the 24-hour period, because in the event that nursing supervisors are unable to resolve a problem or a concern, the pharmacist on call is available for consultation and problem resolution if the problem can't wait until they're on duty again. A very important point here. Patient profile information, including lab results, should be available to the remote site electronically. You could have oral communication of lab results if you needed to do it that way in a timely manner, but these should be limited to exceptional circumstances. You want the lab results and the clinical information documented as part of the patient's record. As you know, if it's nothing but a fax that is scanned to the console, you want that documentation there. And whenever there's a need for oral communication, it should be documented in the patient medical record just as soon as possible. And then, like I said, a backup plan so that downtime procedures should provide mechanisms for a direct communication among the remote pharmacists, nurses, and prescribers. Communication, communication, communication. So, if you're ready to go with this and you get to the point that you're looking at implementation, I'll just say that the success of remote medication order processing and utilization of remote pharmacists, the implementation will depend on a host of specific factors. Depending on the terms of the contract or the agreement between the hospital and the remote pharmacist, there may be a need for allowing flexibility for the number of orders processed, since you start with your best estimate of how many orders there are, but these estimates prior to go live may be inaccurate. So if the reimbursement is based on a per order basis, just allow some flexibility in there to see if it's more or less than what you had been counting on. Also, I would say early and frequent communication between the hospital and the remote pharmacist site is especially important, and especially in the first few weeks after go live. It's critical to the success of implementation in the ongoing operation. Now, after hours technical support at both the hospital and the remote site will be essential to the success of the implementation and ongoing operation. So you need to plan for these IT resources and IT support in advance of the go live. In fact, your IT folks need to be intimately involved with what's rolling out. They're probably going to have to help set up some of the processes and some of the connections, but you can't involve them too early in the process. Another thing would be education. Education will be required for all nurses at the hospital, and I said all nurses, not just those whose shifts coincide with the remote pharmacist coverage. Something I thought of as I was planning this, and that's you have to watch out for the little foxes that can ruin the vineyard. And by that I mean you will be surprised when you start implementing what it is that becomes the issue. It may be something as simple as a fax machine not communicating well with the PC, and you need to get a multifunction machine in order to be able to fax orders into the console. Any little thing like that, and it's not usually the big things that you are counting on, it's the little foxes that ruin the vineyard. Checklists are not just a good idea when it comes to implementation. Checklists are crucial, so plan to work off of a checklist. And the client, the hospital, should also implement a mechanism for communication between the remote site and nursing via the electronic medication administration record system. In other words, it shouldn't all be conducted by faxes and phone calls. There should also be a way that when nursing looks at the EMR, they see where the pharmacist has been. There's a place for the pharmacist to make a comment or to put in some extra direction related and connected to a specific order. Though most of the systems have those capabilities built right in. So be sure that there's education so that everyone knows how to use those. And then in addition to a more urgent method for communicating, which would be the telephone or the fax machine. And finally, have I said this already? Communicate, communicate, communicate. Now, I promised you that before we finish today that we would look at some programs and initiatives that are out there to support what we're talking to you about. And so we'll wrap up by mentioning some programs and initiatives moving us toward enhanced medication management, moving us toward reduction of adverse drug events, and better care, better health, and less cost to our healthcare system. Now, I expect you are fairly well informed of the requirements and the challenges for small rural hospitals in meeting EHR meaningful use. So I won't spend a lot of time on that, except I will extend my empathy. It is extremely challenging. And when you're talking about EHR meaningful use, what we're finding out is the CPOE portion of that is really the most challenging, both due to technical situations, but also due to the culture of your hospital and the way things have always been done. So, once again, being what I refer to myself as a recovering critical access hospital administrator, you have my empathy. Another project aligned along with meaningful use and this idea of improving medication management is ORHP's, the Office of Rural Health Policy's Medicare Beneficiary Quality Improvement Project, and particularly the Phase 3 portion of that project that starts this September. And what this is pharmacist review of medication orders within 24 hours. As a critical access hospital participating in the MB-QUIP project, you will need a cost-effective way to comply with this standard in Phase 3. And you need a solution that makes sense in your hospital. And that solution may not be just go out and hire a full-time pharmacist. In fact, if you don't already have those resources, you'll find that it's probably easier said than done. So, remote pharmacist services may be just what you're looking for, a cost-effective way at a fraction of a cost of what a full-time pharmacist costs, but to yet meet the level of business that you have, the level of patient care that you need to provide in a way that makes the most sense for your facility. Another initiative, in addition to those two, is the Partnership for Patients. And my work with the Partnership for Patients, it's become so clear to me that as small rural hospitals, we cannot begin to address harm and hospital-acquired conditions until we address adverse drug events and what I would call just good medication management. I have a slide burned into my retina that is done by the Agency for Health Research and Quality, and it's a pie chart showing the different healthcare-associated conditions, and 34% of that pie chart for all hospitals across the country is adverse drug events. And if you look at a small critical access hospital that maybe is not doing OB delivery, does not have a very robust surgery program, doesn't see but an occasional ventilator patient, that percentage goes from probably 34% up to around 50%. So most of the harm that is happening in your facility is probably related to an adverse drug event or an adverse outcome with medications. And as you look at that pie chart, you see also that it will also be boiled down to just about 3 classes of medications, that being anticoagulants, hypoglycemics, and opioids that cause most of the adverse drug events. So it's clear, unless we take this seriously, we won't be addressing the harm and the hospital-acquired conditions that we're causing patients in our facility. Now, beyond that, the Department of Health and Human Services, HHS-wide, has an emphasis now on adverse drug events. They've established an interagency priority of addressing adverse drug events through this federal interagency committee. And they're utilizing current technology to have the medication experts, the pharmacists, engaged. That's key. So, for those of us on this phone call or this webinar today, our call to action is simply this: to make it happen. And once again, I mentioned earlier on in the webinar that a copy of the ASHP guidelines on remote medication order processing is available at this website listed on this slide in front of you. And I want to give a special thanks to the American Society of Health System Pharmacists, to their Council on Pharmacy Management, and the expert panel that authored much of the guidelines that I've shared with you today. And a special thanks to you for answering the call to action to make improved medication management and patient safety a priority, and for your effort to leverage the very technology itself to make that happen. And thank you again for your participation on this webinar today.